Hi, my name's Krisytn Heins. Today we're going to be looking at the 4-quadrant model of integrated care. The 4-quadrant model was designed as a guideline to various levels of integration. It describes the different treatment levels in physical health, mental health, and substance use provided at different facilities and which fall into each quadrant. The idea behind this was not to say that every clinic will fall into these, but just to kind of give a general guideline. So quadrant 1 looks at for the severity levels, low complexity or acuity for physical and mental health. So usually we're going to see this as just like a general primary care clinic. The appropriate population, or the population most served here, is going to be someone who presents to primary care with maybe some behavioral health or substance use, and some health and behavior concerns. They're usually a pretty well managed patient on the physical health side of things as well. So again, this patient is seen in the type of setting. We usually have a PCP to manage their medications. The universal screening tool can be useful here to help identify mental health concerns. So just a basic tool that looks at symptoms of anxiety or depression, might ask about substance use. Some might ask about thoughts of suicide. Others might look at maybe questions that ask about a mood disorder. So just a really basic screening tool just to check in maybe once a year and make sure that the patients are doing well on their mental health side too. A behavioral health consultant can be utilized to provide brief screening and intervention here, as well as consultation with the PCP. So they may not have a full-time mental health clinician on staff. Maybe it's somebody who's there couple times a week or checks in, or maybe they just check in via phone call to a contact at the clinic and see if there's any need or any concerns. Or a behavioral health clinician might be full-time there, and they might do something like work part-time in integrated care and have outpatient caseload as well. This person can be used to look at various screening tools, or just consult with primary care physicians if maybe they have a question about symptoms and severity and what that might mean. Behavioral health clinicians can be utilized to complete simple screening tools, like I said, like the PHQ-9, GAD-7, MDQ, or even the Vanderbilt assessment for ADHD might be something that they consider using here. Health and behavior intervention can also be utilized in this setting as well. Motivational interviewing for diabetes management and med compliance. If somebody is just not checking their blood sugars, not taking their insulin, not taking care of themselves, they haven't changed their diet, they haven't become more active, and the primary care physician can give them all this information that they need to make changes, but maybe doesn't know how to motivate them to make a change. That's where a behavioral health consultant or clinician can come in and maybe work with this patient and figure out what's stopping you, what are these barriers, and what would it look like if you were able to do this? How might we get there, and what might stand in the way? Another usefulness for a behavioral health clinician in this type of setting is non-medication coping strategies for ADHD. So working with parents and children on organization or planning, and just giving different options if the parent doesn't want to start a child on a medication. Other psychoeducational things like healthy lifestyles, healthy relationships, setting good boundaries in life, sleep hygiene techniques. All of these things can be addressed by a behavioral health clinician in this type of low severity, low acuity setting. So quadrant 2 looks at the severity levels of low complexity or acuity with physical health and high acuity or complexity with mental health. So usually at these we're looking at a specialty mental health clinic, community mental health. You might see inpatient mental health treatment, detox, residential treatment, crisis residential treatment. Residential treatment being a more long-term, perhaps that person lives there for the rest of their lives, or they live there for a couple of years, whereas crisis residential treatment is more of a brief inpatient type setting, not as intensive as a hospital. Maybe it's not a locked facility, and they're usually there for 3 to 4 days just to kind of get regulated on medications or something. The appropriate population for this type of setting is a patient who presents with severe and persistent mental illness, or SPMI is something you might hear called, substance use disorder, suicidal ideation, plan, or intent, Usually you're going to see a higher severity here, not just like a mild or moderate depression. So a patient seen in this type of setting will have usually a psychiatrist or another prescriber with a specialty in psychotropic medication. So that might be like a nurse practitioner who specializes in psych meds, a clinical pharmacist who specializes in psych meds, or even like a physician's assistant might be there too. But usually we're looking at psychiatry treatment. Some consultation or collaboration might be made with the primary care physician to offer the holistic treatment plan. If this is the case, usually it's in the same medical facility, so maybe the primary care physician is part of the same system as the hospital, or obtaining a consent for release of information can be used here to coordinate with the primary care physician. The use of physical mental health inpatient units is also seen here for treatment for post-suicide attempt or during detox. So these are not very common to see, but these are the types of inpatient settings. So if somebody attempted suicide by overdose or by causing some physical harm to themselves, and they are high acuity for physical health as well as mental health, they might be in one of these types of these settings. Detox is also something where we're going to see more coordination between a physical health doctor and a mental health physician. Behavioral health clinicians working in these settings should have a strong assessment and treatment planning skill set. They need to be able to do full psychosocial assessments, using the screening tools for mental health or substance use disorder. There's generally a high collaboration between various disciplines on a treatment team. You might have a treatment team meeting in the morning where a patient is presented and all the different disciplines are going to be weighing in on this person's treatment. So being able to collaborate and understand each person's role is really important. Patient-centered treatment plan, including all healthcare providers, is also important here. So that's where you'll see the collaboration piece on the various disciplines. So in the third quadrant, the severity levels are high complexity and acuity for physical health and low complexity or acuity for mental health. So usually in this setting we're looking at primary care, specialty medical care clinic, like physical rehab facility, a nursing home, inpatient physical health care, maybe like a post-surgery stay. The appropriate population that you'd see here is a patient who presents to primary care or is engaged in specialty medical services with minor behavioral health concerns. So the main provider here might be the medical doctor, and there might be a consultant on scene, a behavioral health consultant there to be used for screening and brief intervention. Again, we'll see the universal screening tool here usually to help identify any mental health concerns. There might be a referral to long-term behavioral health treatment if needed. Behavioral health interventions might include like psychoeducational information and coping skills, healthy lifestyles, importance of medication adherence, community resources, that kind of thing. So something else to look for here is if somebody is having a really complex physical health issue, it might be affecting their mood. They might start presenting as more depressed or less motivated, maybe their hygiene skills have gone down. So this is where behavioral health kind of steps in and helps on the medical side of things to help screen for any sort of mood changes associated with physical health issues, and also maybe helping by using motivational interviewing or something to help get that patient back on track. In the fourth quadrant, the severity is high complexity and acuity for physical health and mental health. So here we're really looking at like residential treatment, assertive community treatment teams, primary care and specialty medical health and mental health. The assertive community treatment teams are usually a team of case management, psychiatry, therapists, nurses, and they're checking in with these patients daily, sometimes weekly if they get well managed. The residential treatment is generally where somebody's going to stay for the rest of their life if they're having severity in both of these categories. And a patient with chronic mental health and physical health concerns is who you're going to see in this type of population. So here there's going to be a high level of collaboration between primary care and RN case managers, mental health providers, and community case managers, behavioral health clinicians, maybe in a case management type of role here where they're helping the patient meet their basic needs, getting their bills paid, getting groceries, taking them to appointments, making sure they're on track with all of their treatment. Shared medical records are really important here, or getting a release of information is important to help with the integrated approach to treatment. People who are usually seen in this quadrant, they need the collaboration between all of their different disciplines and providers. So medical and mental health clinics fall under the spectrum in these 4 quadrant systems usually. Every clinic's a little bit different, so it can be kind of a spectrum, but generally speaking, these clinics are going to fall in one of these 4 quadrants. And communication and collaboration is imperative in each quadrant for a holistic treatment approach. We want to make sure that we're communicating all the time with all of the providers to ensure that the client is getting the best care that they can get. Behavioral health providers can be utilized in each quadrant as the primary providers for the client or just as consultants maybe. But there is a place for behavioral health in each of these quadrants here.
Hi everyone, and thank you so much for being here today. Before we start with our first discussion on the 4-quadrant model, what I'd like to do is just go around and have everyone introduce themselves really quickly so our audience knows who we're having our discussion with today. So we can start with Dr. Saxvik.
Hi, I'm Dr. Kendra Saxvik. I'm a clinical pharmacy specialist. I specialize in mental health, and I work over in specialty mental health care at the VA here in Corpus.
And I'm Dr. Pam Green, and I'm a lifelong, it feels like, psychiatric nurse. And currently I teach in the College of Nursing and Health Science here at Texas A&M University, Corpus Christi.
And I'm Krisytn Heins. I'm a LPC, and I work in primary care mental health over at the VA outpatient clinic.
Thank you. And my name is Julia Zalakula. I'm one of the program coordinator or assistants for Tex-CHIP, and so we're going to get started. Thank you guys all for being here today. We're going to be starting off with the 4-quadrant model. So my first question to you guys is kind of, in reviewing this content, given the sort of geographic location of our university and where we are located in South Texas, how viable do you feel that something like this is on a systemic level?
I think the 4-quadrant model allows for different levels of integration depending on each clinic, and so I think that no matter where you're located at or what resources you have, there is the ability to fit somewhere in one of these quadrants and have some level of integration. Even places that don't have a full-time mental health therapist on board, they'll still have access and availability somewhere. Maybe it's through the internet or just other local resources.
Thank you.
I think that probably in our geographic location, most of our systems are probably still within quadrant, or most of our patients are probably still within quadrant 1 that most primary care are seeing. Although I do see that there's probably a significant portion of our older population that follows into quadrant 3, which is the more high intensity physical but less intensity mental health. But we have a lot of uncontrolled diabetes and in and out of the hospital for those things. So I think that that's probably a section of geographically where we can really focus on moving forward with integrated models.
And I think sometimes just even helping people recognize that they're already doing some of these things into quadrants 2 or 3, and they might not have even recognized that that's what they were doing. So sometimes I think that helps make that more feasible when you realize, oh, we are doing this already. So having the different quadrants spelled out so clearly is helpful, because then people can recognize for themselves it's not such a huge stretch. It's not far off.
Mm-hmm. Absolutely.
I agree.
Thank you. And when we're looking at institutions that we have in our local community who are serving individuals who aren't necessarily within the healthcare system, how viable do you think this is for those institutions?
I think actually that will help give them a framework with which to kind of think how they're already doing some of these things, and the framework as how their patients are and where they can potentially move towards a more integrated model. For example, that quadrant 1, the low intensity physical, the low intensity mental health. I think a lot of those patients are being seen outside of the healthcare systems because they don't have a lot of other healthcare needs, and so they may not have made it into the system, or our more intense patients may not be able to afford to be within the system. And so I think, again, both of those quadrants are a place where we're already doing some things outside of the healthcare system, but maybe not recognizing it, just like you said a little bit ago. And so I think maybe giving providers operating outside of that system a framework to think about how they're doing things, and then what's the next step? How can I make it a little bit better for my patients?
Sure, absolutely.
As you were speaking, it made me think about the single point of entry that is being developed for the homeless population in this community. And they're really talking about a system that connects so that if a person is entered into the system, other points know that this person's in the system and they know what has been done, kind of a case management. And again, I think it's, they're looking at many, many factors, not just healthcare, but I think that again, that idea of saying, oh, in fact, we're doing A, B, and C here, and it fits with this. So sometimes I think, again, more is being done even outside the healthcare system than might be recognized. And having the framework so nicely outlined, it just will help them see how far along they are in the process.
Mm-hmm. Yeah, and I think it can help give ideas on how to expand services for that person that might fall into one of the more severe quadrants there.
Mm-hmm.
Absolutely. Thank you, guys. And so when we're shifting a little bit now and looking at this 4-quadrant model with regards to sort of the culture of engagement in this area that we have, what do you guys think about that from like an ethnic perspective?
Well, I'm thinking very limited first, and then we certainly will expand. But even here on the university campus, we have a lot of countries represented in our international student group, and we're just finding out as we're doing some of the training in our gatekeeper training for helping individuals recognize and access assistance for mental health care. Students from other countries have been very verbal that this is not acceptable because of their own culture. And so it has helped us start thinking about people who are more native to this area, what we have to do to be more in tune, because there is so much stigma involved and many myths and many misunderstandings about healthcare in general, but especially about mental health care and about ways to also honor some of the more adjunctive kinds of therapies that people are used to using, and so we're actually at the point of probably raising more questions and answering with this and as we uncover barriers that we didn't even recognize before.
Absolutely. And Dr. Green, you spoke a little bit about the sort of the stigma that's associated with mental health. Do you guys think that that's something that will be encountered as any of these integrated approaches are kind of implemented into institutions?
Oh yes, there's a large stigma still associated with mental health, and that does play into also the ethnic considerations. That there is cultures in this area in particularly that have a large machismo component, and so it can be viewed as emotional weakness to be able to seek out mental health. And that is a huge barrier to overcome. When we're thinking about within the context of the 4-quadrant models, that stigma can come with, I'm not here to see you for my mental health. I'm here to see you for my physical health. And one of the ways that we can kind of start breaking that down is like, well, you are here to see me, and this does play a role. They are integrated. You have very uncontrolled diabetes and you're at risk of losing your foot. I would be upset about that.
Sure.
How can we now move forward and help with that? And so to kind of wrap that thought around is these different quadrant models can help give a framework of where each patient is at, and how do we address the barriers for that type of patient?
Absolutely.
Yeah, in the position that I'm in now in primary care mental health, where we get called into the room to see the patients who are there for primary care, sometimes they're a little resistant to it, like, no, I said I didn't want to see you, I don't want anything to do with this, but
just not good.
yeah, exactly. But other times people can kind of come around and think like, okay, I can see where this is affecting me, I might be interested in talking with you, and I think just having that really brief interaction with them right away can kind of get them to buy into the process a little bit more, and so we can maybe get them into a different quadrant of care if that's what they need, but at least at that quadrant 1 of primary care is just getting that foot in the door with them and welcoming them and letting them know that services are here and it's okay.
I have a question, because you do work there directly now. Do you think it is more palatable because they're in primary care and you come to them versus them having to go out?
Absolutely. I absolutely think so. And there's a lot of research too that shows that if we can catch them same day while they're there for primary care, they're more likely to come back versus if they're just given our phone number or told to call, or if we call them for follow-up. As soon as they walk out the door, it's like, okay, well, I'm done with that. I don't have to go back. I don't have to deal with it. So sometimes it might be a little bit intense for them, for somebody to walk in and say, like, I'm here, whether you wanted to see me or not, here I am. But I do think overall it creates a more welcoming environment, and there's a much greater likelihood that they're going to come back and see me again. It's much less threatening, I think, than saying, like, okay, here's your referral to a mental health clinic.
Because again, it's like if you're having a hard time swallowing mental health, it's like, well, I just have to go see somebody, and I'm walking into my primary care.
Yeah, and I do think that there's an added piece there too, that they're not going to a specialty clinic or something. It's I'm going to the primary care doctor, so they can even tell like their work if they need the day off. I have to go see my PCP or something. So it's much less threatening, I think.
Absolutely. Okay. Well, with all that being said, can you guys just talk to us a little bit about some of the overall opportunities that the 4-quadrant model offers?
I think particularly when you're looking at somebody who's got a high acuity, either physical or mental health, it's a good place for like case management to come in and help get all of the services that somebody needs. And I think when looking at the quadrant model, a case manager would be able to say like, okay, this is maybe where this person fits. These are the services they might need. How are we going to get this to them?
And how can we get them from one of the more intense quadrants to one of the more low intensity quadrants? Because we often think about medical conditions, which would be the quadrant 3 and quadrant 2, that we can treat those. We can get you to a better place, right? We can move you down in intensity. Yes, you just got out of the hospital, but we can get your diabetes under control, your blood pressure, things like that. And sometimes we don't necessarily think about it the same way with the mental health. But really, to be able to fully move them down in intensity level medically, you need to address their mental health as well, because there may be barriers that you just don't see. We'll use diabetes as an example. I don't want to take my insulin because X, Y, Z. Okay, well, mental health can help us in motivational interviewing or things like that not only helps their mental health, but also their physical health. And so I think, again, the quadrant model gives a framework on where we can start to target those type of interventions with the goal of moving them down in intense quadrants.
Absolutely. Well, thank you guys so much for your input on this topic.